Dr. Bruce Goldberg is currently a professor at the Oregon Health and Science University, Portland State University School of Public Health. He led Oregon's nationally recognized health reforms, transforming Oregon's Medicaid system to one based on a model of coordinated care.
My pleasure. Thanks for having me here. It's a pleasure to be here. This has been great. And I think let me just echo a couple of messages even before I start. And they're the messages echoed by both Mark and David. One, there's no perfect structure. Two, you're on a journey and you're really to be commended for that. And I would just stay on that. So I'm going to give you sort of Oregon's journey and where we started, where we're going, etc. But let me first start with this. I was the director of Oregon's Health Authority. My dad reminded me that when I was a teenager in the 1960s, I did nothing but question authority and wore a button like this. And he was not in healthcare, but then he thought it was just comeuppance that I was then the director of a health authority, which he had no idea what it did. But he always then thought it was a good thing to question authority. So what I want to do is talk to you a little bit about governance and authority, Oregon style, but going to separate it out into two chunks. One, an effort we did around governance and authority of the state infrastructure, and then two, what we've done around governance and authority in the health delivery system, because a little bit different. So our environment, very similar to this is 2008 when we started this. Our environment was long history of health reform dating back to the early 1990s, but yet healthcare costs rising faster than any other economic indicator, really starving out public dollars from other public purposes. And then the other issue that you've heard about was quality being pretty random. I mean, I usually show a scatter plot of healthcare quality indicators, and you can take that to any state, any community, that we have no consistency in quality and in delivery. And we had a belief that we could do better, that we really could. And we felt that we could do that in a couple of ways. One was to harness the state's efforts at purchasing. I talked about not a lot of consistency. Well, we were some of our own worst enemies. We as a state purchased health care for Medicaid, for public employees, for teachers. We purchased mental health and behavioral health services. We purchased public health services. And we did that in an inconsistent way with a confusing process, multiple standards, and felt that by consolidating purchasing, we could, A, improve value for the state, and B, we could begin to use that purchasing power to drive changes in the delivery system. The state purchases for somewhere between 30 and 40% of the people in the state. That includes educators and their families, public employees and their families, Medicaid, a whole variety of others. And in fact, in some towns, like Salem, our state capital, where there's a large number of public employees, the state purchased health care for over half of the people in Salem. But we did that in a really haphazard way. So one thing was use the purchasing power of the state to align things, be a better purchaser, which many in our delivery systems really liked. If you're a physician or a hospital and you're contracting with 60, 70 payers, all of whom have a whole variety of standards around quality and delivery of care, it's no wonder we have large infrastructures, tremendous amount of missed opportunities to consolidate some of what we do. We created a health policy board for oversight of this and for policy development. And at the same time, we established some of the mechanisms for insurance rate review, although that was a bit of an aside in the effort that we were doing. We looked to take not a regulatory approach, but a purchasing and a policy and a data approach, as you'll see. And our goal was really begin with Medicaid, get our house in order in terms of how we purchase care in Medicaid, and then begin to expand that into purchasing for public employees, teachers, and others, and then looking to extend out into the commercial market. If you read the bill that established this, House Bill 2009, there's a link at the end of this. This was in 2008, 2009. We actually anticipated a state-run insurance exchange, much like happened nationally. So we created, as a part of this, one was the Oregon Health Authority. We had a very large state agency, much like you have, a Department of Human Services, that was all-encompassing. It did everything from child welfare and senior protective services, at the time food stamps, now SNAP, to Medicaid purchasing, mental health, public health, you name it. Huge span of responsibility, 11,000 employees, child welfare workers, et cetera, and a lot of very different missions. So we created a new agency, the Oregon Health Authority, that consolidated all of the health programs from the Department of Human Services, Medicaid, public health, all of the behavioral health, mental health, substance abuse, public health purchasing, and also took from other parts of state government the purchasing for public employees, for teachers, and for a variety of, at the time, what were smaller healthcare programs that the state run, and put that into one agency. It was overseen by a health policy board. And the charge to the Oregon Health Authority was to begin to develop uniform contracting and quality standards for the state, to run all of these programs, to establish evidence-based guidelines for care, to have consistent health policy development for the state, and to coordinate the state's analytic and policy support. A lot of that analysis and policy was being done in a variety of different agencies, and the whole idea was to consolidate everything. We also established a board to oversee this. Much of the same discussion as you heard Mark and David talk about. Is this going to be a Noah's Ark, meaning representative, one from each species in the healthcare world? A doctor, a hospital, you can go on and on and on, or was it going to be, a group that wasn't representative, but that really established a broader look at the state? We landed, so you heard 5, you heard 11, we're at 9. There is no magic number. We landed at 9. These people are appointed by the governor and confirmed by the Senate. The only mandates on it were a couple. There needed to be one person from each of our 5 congressional districts, which really looked at geographic, being certain that the board had a large geographic diversity. We're a really big state. I think our state is the size of New England. And we have a pretty big urban-rural divide. We've got a frontier part of our state where we have one of the last few public boarding schools, because kids travel an hour to go to public school. And then we have, Portland, Oregon. So that was to establish some geographic diversity, and it just mandated one practicing physician to be on the board. And then there's a list. This is consolidated. In the establishing legislation, there's about a list of 20 or 30 functions that have all of the same buzzwords you and I have all heard today about value-based purchasing, contracting, lowering healthcare costs, access, public health, you name it. It really boiled down to the group being the policy-making body for the health authority, developing a plan for affordable quality care for all Oregonians, establishing statewide healthcare quality standards. That was really key to what we were looking to do. Looking at establishing cost containment mechanisms, and we'll get at that in a second, and assure a sufficient healthcare workforce. Those were the key charges to the Health Policy Board. The authority of the board, well, now we get into, do you have authority or influence? And what is real authority? When you look at state government, the real authority generally is around a governor and a legislature. In our state, we talk about it as 16, 31, and 1. We have 60 in our House. You need 31 votes to pass something. We have 30 in our Senate. You need 16. And then we have a governor who needs to sign a bill. And ultimately, that's where the authority is. But there's a lot that can happen, and you heard about that through both examples, through how you establish that influence. And to talk a little bit about that. The policy board has the authority to submit legislation, which is somewhat unique, but ultimately you need 16, 31, and 1. And they can organize and oversee the work of the Oregon Health Authority. This was in some ways a big effort in restructuring state government. At least that's what we thought going into it. It turned out to be, as in our political parlance today, a bit of a nothing burger in terms of how we did that. We had 2 years to transition, and we took care of that by setting a couple of parameters. Number one, there were no additional FTE that were put to this. There was a lot of concern that when you established 2 agencies out of 1, that you would now, what was it going to be that you had two directors, a director of DHS and a director of the Health Authority, and all these other things. Well, we actually found that as we went through this, we mapped all of the employees, all of their functions, and to be honest, we found a fair amount of ability to consolidate and to actually reduce some positions as we really diligently mapped this out. We had a 2-year time frame to do this transition. I think that the wisdom of our governor really helped, which was I was the director of the Department of Human Services. He had me share the role of both director of the new Health Authority and director of the Department of Human Services during that 2-year transition to avoid what he called bickering bureaucrats, which was really appropriate. So we were able to do that. We have a 2-year budget cycle. We took 2 years to transition the agencies. It actually went, as I indicated, pretty smoothly. The 2 agencies still share a fair amount of administrative infrastructure. As one agency, we shared the same telephone system and IT system and HR and some of those administrative functions. And we simply decided to continue that and to have a shared administrative infrastructure, which we set out some clear charters around governance and how that would work. And in a lot of ways, the agencies ended up running probably a lot more smoothly at the end of that transition than they had been at the beginning, primarily because there was a tremendous consolidation of missions, certainly on the healthcare side, and as well as on the human services side. As I indicated, this was done without any additional staffing, mapped out all of the staff, and was able to move forward. And now this is how our structure looks. We had a huge Department of Human Services. Now we have a health authority with Medicaid, public health, behavioral health, purchasing for employees and teachers, a variety of other health purchasing programs, and a consolidated policy and analytic structure that runs an all payer, all claims database, etc. We have the Department of Human Services overseeing the health authority by the Health Policy Board, the governor, and the legislature. We have a Department of Consumer and Business Affairs, where insurance functions of the state are run. We don't have an elected insurance commissioner. It's the director of the Department of Consumer and Business Affairs. And that group does some commercial health insurance rate review, which has gotten some notoriety nationally, but again, that's overseen by a separate agency. Advantages, disadvantages, I think consistent health policy direction for a state is something that was welcomed by, I think, a lot of stakeholders. There was a single point of accountability for health and for healthcare purchasing from the state's perspective, and a place where you could really focus a state's effort on whatever goal you want, whether it's better health, quality, access, etc. An ability to leverage a fair amount of the state's purchasing to promote better value, both for the state's purchasing as well as, I would say, better value for the delivery system to not march to multiple drummers. Greater efficiency in the delivery of care. Certainly some consolidated efforts around data analysis, policy, and technical support. And lastly, a consistent platform for multi-payer efforts. And then as we did this, we had a sudden environmental catastrophe. That catastrophe was the Great Recession, where we had set up this infrastructure, we were ready to move forward, and state revenues dropped 30% in like a day. The need for Medicaid services increased dramatically the same day as people lost employment. Healthcare costs were continuing to rise. I mean, it was really a catastrophe. And we looked at how states deal with this. And states in the private sector, pretty much all of us, deal with rising healthcare costs in the same way. We're just, some of us, a little more subtle about it. Number one, we cut people from care. States are good at that. We threw 100,000 people off our Medicaid rolls overnight because our state budget plummeted. But businesses do that as well. When I came to Oregon, pretty much every business offered fully paid family health insurance. Nowadays, businesses, it's pretty rare. The worker may get covered, but hourly workers have to pay $300 or $400 for family coverage, and they can't afford it. So they were ostensibly cut from care as well. We cut services and benefits. States do that. We all talk about what covered benefits we have. And the last thing we do is we cut payments, or we shift payments. We either cut what we pay providers, or we shift the share of that from now I'll only pay 70% and the consumer is going to pay 30%. And we have used these same tools in public and private sector for probably since all of us were born. And I would say, what effect has that had? Have we lowered healthcare costs? No. Have we really seen the kind of dramatic improvements in consistency and quality? No. So we felt we had to do something different. That dealing with this catastrophe meant we just had to do something different. And that was to create a fourth path. Rather than cutting rates and cutting people and cutting benefits and doing all those crazy machinations that drive all of us crazy, we wanted to figure out how to get at the root of how care is delivered, to fundamentally change how care is delivered, to be able to reduce waste, improve health, get at all the things we want to do, pay for performance, etc. This is waste in healthcare. We all know this. This is Don Berwick. Anywhere between 25 and 50% of our healthcare dollar is wasted. You can take whatever number you want. If it's 5%, it's still too much. We also know that a lot of what we contributes to our health, and I always lose my doctor union card when I say this. It's not about the doctor or hospital we go to. What contributes more to our health is our zip code, it's our social environment, it's what we eat, it's what we drink, it's what we smoke, it's what we shouldn't smoke. Social factors are a lot more about our health and our health status than our medical care. Yet, about 10% is medical care, but that's where 99.9% of the dollars go. So how do you start to focus on some of all these things? And this is where everyone goes, yeah, great, Bruce, but what does changing healthcare delivered look like? And let me just tell you a quick story, because this, I think, exemplifies what changing care looks like. This is Malik. Malik is a 12-year-old boy, and he's got asthma. And Malik was going to the emergency room every month. Now, Malik had really good health insurance. He had a really great pulmonologist. He got every new medicine that had a Z and X and a Y in the name. I mean, he had it all. But he would keep going to the emergency room every month until he got enrolled in a new community-based program where we sent a community health worker out to his house. They helped look at what was causing Malik to wheeze. They actually removed some carpets from his house, helped the family pay for some new carpets, bought the family one of these new HEPA vacs that get all the dust out of the room, taught his family better how to use all these great medicines he was taking. And a year later, Malik was not in the emergency department once. Now, think about that for a second. I'm a family doc. I've taken care of thousands of Maliks. No one pays me for a community health worker. In fact, community health workers, when we started this, you can't even pay them. They didn't have a code to be able to pay them. In fact, I got perversely paid more. I mean, I got paid every time Malik was sick. I didn't get paid when Malik was well. So think for a minute how things would look differently if the charge was, no child should ever have to go to the emergency room with an acute asthma attack. And that sort of is what changing care delivery is about. How do you create a system where we all work together to keep Malik out of the emergency room? And that means really thinking differently. It's not about having a system that pays for office visits. Or it's how do you start to create a structure where you have community health workers. You look at illness and prevention and community health in a whole different way. So to do that, we created coordinated care organizations. It was our belief that all healthcare is local, that you could draw a circle around a community, and it's about the people, the hospitals, the doctors, it's about everybody in that community. And how do you bring them together to do exactly this? So we created a coordinated care model. It's got 5 tenets. I'm going to talk very briefly about a couple because they're germane for today. Local accountability and governance, a global budget, integrated and coordinated care, quality metrics, and flexibility. So we created these new organizations called CCOs to deliver care in our Medicaid population. The whole idea was to create a new community-based organization that was governed by partnership between the 3 entities we felt were important to improve healthcare. Those taking financial risk, those who provide the care, the major components of the healthcare system, and consumers. So governance of these new CCOs had to include that. We went through every machination, same thing about Noah's Ark, big, small, little, whatever. We left it blank. And that was in the contracting process. The organization had to meet, in essence, the Supreme Court definition of pornography. You know it when you see it. We knew it when we saw it, when the governance really represented risk takers, components of the healthcare system, and the community. These organizations got a global budget. And sort of little similar to what Massachusetts did, a different flavor. These were Medicaid managed care organizations in essence, but with a new governance style. They were given a budget that grows at 3.4% per capita a year. Why 3.4%? Isn't it interesting? Massachusetts at 3.6. We're at 3.4. We looked at what state revenues were supposed to grow over a 10-year period. And guess what? Just like Massachusetts, it was 3.4%. And we wanted to bring our Medicaid per capita spend in line with what state revenues would look like so that we could sustain our state's Medicaid program. Nationally at the time, Medicaid was supposed to grow at 5.5%. So this was really an effort to bend the cost curve by 2%. And then, you know, the easiest way to meet any kind of cost target is just not to deliver care. So what we chose to do was not just to give a budget, but to link it to a series of quality standards. And to have initially 3% of that budget, now it's 4.6% of that budget, paid out at based on how you do with quality. So we're running out of time. We got a waiver to do this from the feds. We also, at that time, got some money. We got about $1.9 billion. But the interesting thing about that is over the course of our 5-year waiver, we repaid every penny of that to the feds in terms of our lowered costs. And now Oregon's on track to that delta that David showed, saving about $2 billion of state funds over 10 years in our Medicaid program without cutting people, cutting payments, et cetera. We've seen incredible progress. We report on the finances and the quality. This is one look at a public report. Just to give you a sense, we've seen all-cause readmissions go down 18% in the 4 years since we started this. Emergency department visits for avoidable outpatient treated things, 21%. We've seen dental sealants go up 92% in kids. 80% of people in our Medicaid program now are in a patient-centered primary care home. A lot of ways we've seen better value. You can't throw a stone in our state and not hit a community health worker now. It's pretty amazing. We've seen incredible collaboration between different parts of our healthcare industry, a lot less fighting. So let me just spend the last couple minutes with some key lessons learned. First lesson learned, there is no perfect structure. But staffing is really appropriate. And you can't run a multi-billion-dollar healthcare endeavor with staff who are used to running a social service agency. I think there's a real disconnect between state staff who historically have been folks who have run social service programs and the kind of knowledge and expertise of healthcare and the delivery system that you need to run a complex healthcare endeavor. Your Medicaid agency, our Medicaid agency, I mean, these are multi-billion-dollar, large, complex healthcare delivery systems, and you need knowledge and expertise to run them. And I've run organizations on the private sector side that contracted with the state, and it infuriated me, and it infuriated me when I worked with the state to not be able to have the kind of staff, and we eventually needed to grow that. You need some authority, but influence is key. We had hundreds of community stakeholder meetings where we sought to build consensus for what we were doing, and you've got to do that both in community meetings and meeting individually, one-on-one, with insurance executives, hospital leaders, consumers, etc. That was what our governor and myself did pretty much every day. A common vision and leadership are key. Everybody needs to buy into where you're going as a state. Everybody meaning your executive branch, your governor, the agency, the legislature, all of the stakeholders that you have, the industry, hospitals, doctors, consumers, etc. And when I say buy-in to a vision, buy-in needs to be buy-in. Buy-in can't be everybody nods heads at these nice community meetings and then goes off and undermines things when they go home. And we've all seen that happen. There needs to be a common vision, and stakeholders need to be engaged. And everyone has to understand, not everyone ends up getting what they want. Government agency work has to be changed. People can't see in the healthcare side that they can't see efforts at quality, value, all the health reform things as being an add-on. They actually need to be the work of the agency. Payment reform is critical. If you don't change how you pay, you're never going to get there. Multi-payer initiatives are really key. You heard that earlier today. If you're going to make things different, though, you need to help organizations transition. If we're going to save money because we're going to reduce emergency department visits by 20%, well, where do you think that money comes from? It comes from hospitals. So how are you going to help hospitals transition to a different state healthcare model of delivery, whereby they're not actually penalized if emergency department visits get reduced? Data and analysis needs to be reliable and trusted. People have to trust the data. That means being transparent about it, and until you get that data right, and until it's trusted, it's really hard to move forward. Communication, I just can't stress enough. And the last there's a Yogi Berra quote. He said, it could be something like, if the other team wins, it'll be a problem for us. He was right, and that's about Medicare. Never forget Medicare. Medicare is like 50% of your healthcare spend. And so it's great to be doing all this, but unless you're playing with the other teams, Medicare, that's really hard. And don't forget politics also. That under all of this is a political environment. And you can't ever get away from the politics of all this. And that gets us back to community process, like you're doing. It gets back to leadership, like you have in this state. Those are the keys to doing this. So thank you.
We do have time for a couple of questions. I can start off with one. I was interested in finding out, both in Vermont and Massachusetts, there were particular structures in place, such as really long terms for that board of governors, and also distinct funding streams outside of the state budget that allowed that not to be a politically charged environment or variable over time. Is there anything?
Yeah, well, little different. 4-year terms appointed by the governor. The staffing and dollars that go to support the board comes from the Oregon Health Authority. So it's state funding that does that. In essence, as you saw, the board has the ability to oversee and reorganize the agency. And so if they're not getting what they need, they can, within that line between authority and influence, start to get things changed.
Steve, do the microphone.
Thank you, Bruce. Really appreciate this. I'm curious in terms of you went through the Medicaid transformation, which was amazing. But in terms of the having state employees as well as Medicaid and other purchasing authority and responsibility, particularly in the state employee side. I was wondering if you could just comment on that.
Yeah, it's great. So, authority and influence. The goal was to purchase it in the same way. State employees, when they see a reduction in their healthcare spend, see that as a takeaway at the negotiating table. So they didn't want to be put into these coordinated care organizations. And what we've come to has been really interesting, has been we've set the same targets for our contracts for public employees. We want bidders that will agree to bring costs in at 3.4% a year growth per capita. And we have the same quality standards now in those contracts as we do in Medicaid. But that was a hard road to hoe. With one of our unions, it was really interesting. What we were able to do was when we showed them how much we could save in healthcare costs, they were concerned because all that money then ends up going to pave roads. And so at bargaining, they were able to negotiate if they met certain healthcare targets, they got a cost of living increase sooner than they would have if they didn't. So in essence, it was a way to start to share some of the savings with that. But anyone who's negotiated some of those contracts, those are tough.
Question. A question about Medicaid populations. You're dividing into subpopulations, like the big population of mental health and substance abuse, and the aging population. Did you do anything like that, and have the community health workers work in those populations?
Yeah, thanks for that question, because I skipped over that pretty quickly. But we consolidated part of the health authority, and part of what we did in Medicaid was consolidate those funding streams so that the coordinated care organizations get the physical health, mental health, oral health, and a variety of other Medicaid-funded public health streams that probably only state bureaucrats know about that have long acronyms. But the goal was to really integrate particularly behavioral health and behavioral health, mental health, substance abuse, and physical health. And indeed, a lot of what we've seen has been tremendous integration of that, as well as oral health. I mean, we knew in our state that we had a lot of emergency department visits being paid for by health plans because people didn't have access to dental care. I mean, the issue is really starting to look at things differently, and putting those funding streams together is really key. Although not loved by everybody.
Hi. I had a question about when you talked about the Medicaid waiver. At what point in this process did that come through, and for how long, and what's the current status?
We got a waiver in 2011. It was a 5-year waiver. It's now expired and renewed for another 5 years. The first waiver basically gave us authority to change how we deliver care in Medicaid, to put people in a CCO. We were at risk with the feds. We said we would keep spending at 3.4%. If we didn't, we owed a penalty to the feds. And we also said we would improve care, and we would pay a penalty if we didn't. And we got $1.9 billion. The renewal, interestingly, kept the penalties, but we didn't get any more money for the next 5 years. But the states felt that this is a model that's been working really well.
Was that 1.6 for 1 year or?
1.9, the money was over 5 years.
Dan Elliott from Christiana Care and the Bright Health ACO. As you get to the CCOs, could you just help flesh out so I can understand what is the work that's happening there? the generalities of the stakeholders being engaged and, the sort of purchasing streams coming together, that all makes sense. And what does that work look like? And what were some of the characteristics of successful CCOs potentially compared to other ones that didn't perform so well?
Yeah, so, you've got to think about CCO, great term. To be honest, they're Medicaid managed care organizations. They, and I just say that, part of me bristles at saying that because they're not, they're something new, but they really are. They get a PMPM capitation. They pay for the care. They're at risk for the quality standards. What's different about them that makes it really different from Medicaid managed care, I believe, well, two things. One is the governance. We have a long history of Medicaid managed care in our state. It was one of three flavors. We either had Medicaid managed care run by doctors that paid doctors well and everyone else poorly. We had Medicaid managed care that was run by hospitals, which either paid hospitals well and paid doctors poorly. And then we had commercially run plans that paid themselves well and didn't pay anybody else. And so this is new in terms of these organizations are actually governed by a partnership of the risk takers, the deliverers, and the recipients of care. So if someone asks, you got a 3.5% a year increase, and you want to get paid 10% more, where does that come from? And that discussion happens at the CCO level. But they really are, if you think about what they are operationally, all the same functions as a managed care organization. They just have they don't have insurance licenses, they do have to have reserves. They have a little bit of a different regulatory structure.
We have time for one more.
Thank you for talking about the social determinants of health, and these forums have actually been hearing about that a lot. And your story about Malik was terrific. So my question is, how do you think that approach? Are folks doing more of that? Do you think that's accelerating? What other approaches will occur? And what's next on this front?
It's been fantastic. Now, having said that, it's been a great start. It depends whether you're a glass half empty or a glass half full person. I personally think it's been a great start. We have CCOs investing in paying for housing for people who have mental illness because they know that the best way to, actually it's not the medicines you take, it's to have stable housing and a job. We have CCOs paying for workforce training for people. We have a lot of investments in a number of social determinants. It's been, now having said that, that's been a great start. And this is probably a whole nother talk about this, but the ability then to use Medicaid funds to do some of that creates an incredible fight with the feds. But we're doing it. There's a lot more to get done. We'll get there eventually.
So don't go too far. I'm going to give my final question to Steve.
Okay. Well, actually, you answered it in a way. You know that Medicaid has been very resistant in paying for a lot of the social determinants of health or some other. So I was wondering what mechanism you use through the CCO that allows them to pay for those kind of services. Is it coming from their admin or their savings or whatever?
So this gets into the arcane bureaucracy of Medicaid. If y'all can't sleep, you should read some of the Medicaid regs. And not only arcane, well, don't get me started. How do you have a system where you know that housing is the best way to improve someone's mental health and it won't help you pay for it? I mean, that's just crazy. So having said that, your expenditures have to be administrative or medical expenditures. And none of the CCOs wanted to have all these social investments on their admin
ledger, because then everyone would say, oh, look at that bad CCO, they're spending 20% of their money on admin, isn't that terrible? So we created a third category. 2 isn't enough, so now we had 3, which is not medical and not administrative, but it's called health-related services. And that's where we were able to thread a needle with our federal counterparts who have pins, not needles if you're a sewer, to be able to do that.